Welcome to our third session of the day. We're very excited to be presenting on INSTI and metabolic disorders in women with HIV. So we're going to start off with Dr. Lahiri, who I'm very excited to introduce. So Cecile Lahiri is an associate professor at the Emory University Department of Medicine and is in the Division of Infectious Diseases. She works in the Max Wise Combined Cohort Study and is one of the co-investigators and has a research interest in sex differences in the pathophysiology and consequences of chronic HIV infection and its long-term treatment. And we're very excited to introduce her today.
Well, it's really my pleasure to be here with you today, and I'm excited to be able to share some of the work that we've been doing, predominantly looking at integrase inhibitors and associated metabolic disorders in women with HIV. And I'd like to thank the organizers for inviting me to share some of our work today on behalf of my research team. These are my disclosures. So in the 20 minutes or so that we have together, I'm going to take some time to describe the sex-specific epidemiology of cardiometabolic comorbidities in persons with HIV. And then I'm going to provide an overview of the relationships between integrase inhibitors, and I'll refer to them as INSTIs going forward, and metabolic disorders in women. And then I'm going to introduce some omics strategies that our group is employing to try to understand these underlying mechanisms of the cardiometabolic comorbidities, which is something that we really don't understand yet. So I don't really need to show this audience this slide, but as you know, girls and women make up over half of the world's population living with HIV, and a large proportion of that are girls and women in sub-Saharan Africa, which is seen in the green. But despite that, women continue to be underrepresented in HIV research. This is a figure from a review paper that was published in 2016, and they looked over the course of about 15 years in terms of the proportion of women enrolled in HIV clinical trials. And this figure is looking at specifically antiretroviral clinical trials. And as you can see, over that 15-year period, there wasn't really much of an increase, and less than 20% of women were represented the study population of these trials. We did a little bit better with vaccine trials at 38%, but even worse at trials looking at cure. So why is this underrepresentation important? There's a growing body of evidence to show that there is a sex-specific prevalence of non-AIDS comorbidities. So non-AIDS comorbidities differ in prevalence, severity, even timing of onset. And this is a figure that comes from a review paper that we published a couple years ago, led by one of my graduate students, Renee Pond. And we reviewed literature in the pre-INSTI era as well as the INSTI era. And some overall conclusions that we found in the literature is that women with HIV compared to men with HIV have a higher risk of bone, neurocognitive, and cardio and cerebrovascular disease. And then men with HIV compared to women with HIV do seem to have a higher risk for type 2 diabetes, hepatic steatosis, and lipoatrophy. When we look a little bit closer at some of the specific studies related to today's talk, there have been published work looking at the relative risk, HIV versus persons living without HIV, of acute myocardial infarction and cardiovascular disease mortality is higher in women versus men. And studies have shown that HIV is significantly associated with ischemic stroke in women, but not men. And in the alert cohort, women versus men with HIV had higher rates of incident stroke, or TIA. And surprisingly, one of the biggest differences between the sexes was actually among a younger age group, the 40 to 49-year-olds that we don't always think about when we're seeing them in clinic as having a high risk of stroke or TIA. There's a slightly different story when you look at sex differences in metabolic disease. And studies have shown that men versus women living with HIV do have a higher risk of developing diabetes. And in concordant with that, women have superior glucose tolerance. But women are at higher risk than men to develop adipose tissue alterations, although men typically have a higher risk of lipoatrophy. So what's happened in the INSTI era? So as you know, INSTIs are first-line medications for HIV, and they're now recommended in all first-line regimens by the Department of Health and Human Services. They're also recommended by the WHO and are being rolled out in lower and middle-income countries, particularly Dolutegravir. We have 5 approved integrase inhibitors now, the oldest one being Raltegravir. It's been around and approved since 2007. And then a couple of years ago, the long-acting injectable Cabotegravir was approved. But there's a growing body of evidence that I'm sure many of you are aware of over the last 5 or 6 years that integrase inhibitors seem to be associated with more weight gain than some of the older regimens. So here I'm showing a pooled analysis of 8 randomized controlled trials from ACTG in ART-naive persons living with HIV who were starting HIV medications. And as you can see, the persons starting INSTIs, or in the red lines, had significantly greater weight gain compared to those who were started on protease inhibitor-based regimens or NNRTI-based regimens. These changes were more pronounced in women and those of Black race, but I will point out that women made up only 12% of the study population. So even though they were a very small percentage of the study population, the signal of that weight gain signal was still seen in this trial. The advanced randomized clinical trial showed very similar findings. This was published in 2019, and this was a randomized clinical trial out of South Africa, where ART-naive persons with HIV or being off ART for 6 months were enrolled and randomized to either standard of care, which was still an efavirenz-based regimen, or they received Dolutegravir with a TDF backbone or Dolutegravir with a TAF backbone. Women are on the figure on the top, and then men are on the bottom. And as you can see, the participants who were started on Dolutegravir with TAF had the greatest amount of weight gain, and then followed by Dolutegravir with TDF, and then the ones who were on standard of care gained the least amount of weight. Once again, women seem to have more severe weight gain than men, but this cohort was approximately 60% women. So some of these studies really prompted us to ask questions of, what about the women in our clinic that are already on ART, but they're being switched to these medications? So I showed you a lot of data on people who are ART naive, they're starting HIV medications, and it's normal for some amount of weight gain to occur. You're going from a viremic, catabolic state to becoming virologically suppressed on medications. So how much of this is drug-induced? How much of this is just treating the HIV? So we took the opportunity to investigate this using data from the Women's Interagency HIV Study, or WISE, which is now combined with the men's cohort, MAX, to be the MWCCS. But the WISE is the largest interval longitudinal cohort study of women living with or at risk of HIV in the US. And we performed a retrospective observational cohort study, and we compared women who were already on ART, but who then switched to integrase inhibitors to those who stayed on their old non-INSTI regimen. And we were able to look at a variety of outcomes that changed over time, including body measurements, as well as cardiometabolic risk indicators. And much of this work was led by 2 of my mentees, Anne-Marie Kirchberger, who was a medical student at the time, Nate Summers, who was an ID fellow, and then the analyses led by our collaborative biostatistician, Christina Mehta. So our findings were quite striking. What you're seeing here are model-adjusted changes in body weight, BMI, body fat percentage, and then body circumference, which was measured at the waist, hip, arm, and thigh. The women who switched to INSTIs are in blue. The ones who did not are in pink. And the women who switched to INSTIs had significantly greater increase in body weight, BMI, body fat percentage, and body circumference, and unfortunately, the most at the waist. So they gained, on average, about 2.5 centimeters in their waist circumference. And this was a follow-up period that was relatively short. It was about 1.5 years following switch. We didn't see difference by INSTI drug type, but then we took the opportunity to look a little bit closer at predictors of body weight gain. And so we stratified body weight change by baseline clinical characteristics, and we saw that the women who switched to integrase inhibitors who had undetectable viral loads, higher CD4 counts, and who were Hispanic and Black were at the highest risk of having the highest amount of weight gain. And additionally, there was a greater magnitude in weight gain in our older women over the age of 50, and those who actually started at lower baseline BMIs, so who were not obese to start with. The data that I had shown you was predominantly collected pre-TAF based on when the data time frame ended. So when all of these other studies came out with concerns that TAF was maybe responsible for some of this weight gain, we decided to kind of rerun our analyses with additional years of data, and we looked specifically at TAF. And this was done with some colleagues from Johns Hopkins, and we looked at women who just switched to INSTIs by themselves, those who switched to just TAF, and then those who were switched to INSTIs plus TAF. And as you can see, the women who switched to INSTIs alone did have weight gain, particularly the ones who were not obese. There was a little bit of weight gain with TAF alone in the lower BMI category, but not much. And then it really jumped up when they were all put together, showing that TAF exacerbated, but didn't completely explain the weight gain that we were seeing with INSTIs. So was this clinically significant? And that was one of the big questions. So they're gaining weight. Is that clinically significant? Which is why we looked at cardiometabolic risk indicators. And we did see that women who switched to INSTIs had greater increases in their systolic and diastolic blood pressure. We saw that they had worse HDL profiles and that their hemoglobin A1Cs also jumped up, particularly the women who gained more than 5% of body weight. We didn't see any differences in total cholesterol or LDL or incident hypertension or diabetes, but we're talking about 1.5 years of follow-up. So we did see that a greater proportion of INSTI users changed to worse hypertension and diabetes categories. So they may not have developed incident diabetes, but when you look at those who might have gone from a normal A1C to a pre-diabetic A1C, that category change was worse in the INSTI users compared to the non-INSTI users. And most recently, we expanded our research to look at another cardiometabolic risk indicator. We looked at hepatic steatosis. So we know that hepatic steatosis is prevalent in persons with HIV and can lead to fibrosis and significant liver disease. But we don't know what impact INSTIs have on hepatic steatosis, especially with all this weight gain. So this study was led by one of my mentees, Andrew Yu, who at that time was a GI fellow, didn't have much experience with HIV, but was really interested in hepatic steatosis. So we joined forces, and we were able to leverage data from the WISE cohort, as well as the LIVRA sub-study, which is led by 2 of our UCSF colleagues, Phyllis Tian and Jennifer Price. And the LIVRA study captured FibroScan on women enrolled in WISE. So Dr. Yu presented some of this work at ID Week last year, and he started by looking at changes in hepatic fibrosis scores over time. So there's many fibrosis scores that we use in the clinical setting. Some of you might use FIB-4 or the APRI-40 or the non-alcoholic fatty liver disease fibrosis score or NFS. And when we looked at the changes in fibrosis scores over time, interestingly, the only one that increased was the NFS score, and it only increased in the INSTI group. And we hypothesized that that was because that was the only hepatic fibrosis score that actually incorporates BMI into its calculator. But we don't typically use the hepatic fibrosis scores as continuous variables in the clinical setting. We use cutoffs. So we looked at the odds of changing to a higher fibrosis stage over time, and we found that this was increased in INSTI users for FIB4 and the NFS scores, whereas the non-INSTI users really had very stable, they didn't really shift categories for either of those scores. But how does this correlate to what we see on imaging? So this is where the transient elastography or FibroScan data came in. And as you know, FibroScan can measure liver fibrosis as well as liver steatosis, and then it can be incorporated in a predictive score to look for steatohepatitis. And this data we presented at CROI this past year, and we found that women switching to INSTIs did have a 3.7 greater odds of having hepatic steatosis within 1 year of switch compared to controls. But then things seemed to balance out, and we didn't see that increase in odds at later time points. And we didn't see any differences between the groups in the odds of fibrosis. But this is where longitudinal data and follow-up FibroScan is going to be really important to see what that hepatic steatosis within that first year of INSTI switch, what that translates to mean later on. So how do we tease out mechanisms of ART-mediated weight gain and cardiometabolic disease? So what we're doing in our group, we are incorporating data from the WISE and the MAX cohorts for our SPACE INSTI study, which stands for the sex-specific predictors, pathways, and cardiometabolic effects of weight gain with INSTI use. And we've joined forces with Dr. Jessica Alvarez, who's a PhD scientist at Emory with expertise in obesity pathophysiology. And we're interested in looking at how these changes differ between men and women. What are the long-term cardiometabolic effects? I've shown you data of what happens in over 1 to 2 years, but what happens 5 to 10 years out? And we're lucky enough to have that kind of long-term data available in MAX and WISE. And we're using high-resolution metabolomics to try to understand some of these underlying mechanisms. So how are we doing that? So metabolomics is the profiling of small molecules in biologic systems, and it includes all the endogenous and exogenous molecules that we're exposed to. And Dr. Dean Jones and Young-Mi Go are two of our colleagues who have really pioneered the high-resolution metabolomics methods that we use at Emory so that we can measure 20,000 metabolites in a single plasma or serum sample. And metabolome-wide association studies are the study of the association between a measured variable or a phenotype of interest and all the detected metabolites. So you can get a broad measure of metabolism, and you can look at it based on your phenotype of interest. And for us, our phenotype of interest is weight gainers, like who gains weight. So how can we use this? I'm going to show you an example of how we've used metabolomics to try to understand this mechanism. We performed a pilot INSTI study. We took 33 women who were enrolled in the Atlanta WISE cohort who switched to integrase inhibitors. We took their body weights pre-switch and post-switch, and then we took their plasma samples at the pre-switch visit. So at that visit, nobody had been exposed to INSTIs. And we ran high-resolution metabolomics on those samples. And our outcome of interest was body weight gain of at least 5%, since that's considered clinically significant, versus weight maintenance. And so here I'm showing some preliminary pathway analyses that differentiated at baseline between INSTI users who would later gain weight, there were 15 of them, versus those who maintained weight, there were 18 women. So methoxytyrene, for example, is a tyrosine metabolite, was higher in the group that later gained weight in yellow. And then stearidonic acid, for example, is an omega-3 metabolite, which is an anti-inflammatory, and that was lower in weight gainers. So you could do this for all of the metabolism, metabolites and pathways. And this way, we are able to piece together a pathway that tells a story. So essentially what we found when we pieced together these metabolites was that dopamine degradation pathways are upregulated in INSTI weight gainers at baseline, so before they even gain weight. And excess activation of some of these pathways that you see on this slide can cause oxidative stress, as well as impaired methylation, and both of these have been associated with obesity in other studies. And because we're looking at the metabolome before INSTI switch, these pathways and metabolites could be tested in the future as possible predictors of who would later gain weight. So we're in the process of expanding these analyses to 200 women in the Y study. I'm only showing you data on 33 women, as well as multiple time points of metabolomics. So we have 3 time points. So we can actually look at longitudinal change of the metabolome as well. So to conclude, I've shown you today that the epidemiology of cardiometabolic comorbidities in persons living with HIV does differ by sex. Integrase inhibitors have been shown to be associated with body weight gain as well as cardiometabolic risk in women. We're not sure of what that means in the long term for consequences, and we're still trying to piece together the mechanisms. I've shown you that high-resolution metabolomics, as well as other omics platforms, we've also looked at lipidomics, although I didn't show you that data today, can help us understand underlying mechanisms and may serve as a first step to identify preventative and therapeutic interventions. So I would like to acknowledge the Emory Rhythm Research Group, the Emory-CFAR, all the participants in the MaxWise combined cohort study, my colleagues at Johns Hopkins and UCSF, the organizers of this meeting, and of course our funders, particularly from the NIH. And I thank you for your attention.
Thank you so much, Dr. Lahiri. To keep our afternoon session going around sex and gender differences in the INSTI era, I'm going to go ahead and introduce our next speaker, who is Dr. Mandy Willig. She's an associate professor in the Division of ID, as also in the Department of Nutrition Sciences at the University of Alabama, Birmingham. And her research focuses really on nutrition, physical activity, food insecurity, and really promoting healthy aging in persons with HIV. And so she's going to speak with us today with her presentation on care without bias, avoiding weight stigma when managing chronic health in women with HIV.
Okay, thank you. Hello, everyone. Really excited to be here today to talk about this topic, as there has been an increased focus on body weight over the past few years in individuals who are living with HIV. So one of the things I do want to make clear, as I'm showing the disclosures here, is that today when I talk about weight bias or weight stigma, I am specifically referring to negative attitudes towards people with a larger body size. That's not the only type of weight bias that occurs, but that's what we're focusing on for today's presentation. And when we talk about taking care of patients who have HIV or working with research study participants who have HIV and have a larger body size, we have to realize that we're bringing a lot of the rest of the world in with us, our own biases as well as the experiences that those individuals themselves have had out in the world. And that really starts with looking at weight bias outside of healthcare settings, right? And the one thing that everyone really thinks about is entertainment, social media. How is that influencing us, okay? There's quite an extensive body of research that does show that someone who spends more time engaging in social media is more likely to display negative weight bias and display weight stigma, whether that's because they are seeing posts that are derogatory in nature towards someone of a larger size, or whether it's because they're being presented with images of a thinner physique as being more societally ideal a lot of times. So we often don't even realize that we are engaging or being engaged with these types of images or messages. And I think a great example of that is from someone's experiences who was around from before the ages where social media was rampant. And that is Martha Wash here. A few of you might be familiar with her. Miss Wash was an amazing activists for HIV treatment, testing, and prevention over the years. So she has been engaged with many activities of the community. But she was also an artist who sang several songs that were quite well known for many of us here. Right? So one of the songs that she sang was It's Raining Men. If anyone's ever heard that, yeah. So another song that she sang that people are less familiar with is one that was by CC Music Factory in the 1990s. I can see Gen X out there nodding their heads. Everybody Dance Now, in the dance clubs, yes. But people don't always realize that Martha Wash sang that song, because whenever the music video came on television, there's a very slender model who is actually lip-syncing her lyrics in the music video on MTV. And that was not the only song that happened to. And Martha Wash found out that they had made this decision when she saw the video on TV herself. So a very protracted legal battle followed, and it was one of the ways in which people were associating that type of singing voice with a very different type of body than what Martha Wash presented with. And this happened more than once during that time period. So definitely we've been presented with weight bias at times that we ourselves didn't even realize that was occurring to us. But for those people who are living with HIV, for those of us providing care for these individuals, we also have to acknowledge that weight bias occurs a little bit closer to home, right? So in employment settings and education, this is something that we regularly have to deal with. So investigators conducted studies where they looked at negative attitudes towards a variety of factors in the workplace between 2007 and 2020. And what they found is that negative attitudes regarding larger body sizes persisted and had no change during this time period, even as attitudes related to race, ethnicity, and gender did show improvements. Now, some of us might be surprised that those factors showed improvements. And if you are, then think about what is the current situation that people still feel just as openly willing to state how they feel about larger body sizes in the workplace if we feel like we're struggling in those other areas still. And that, in fact, has downstream effects whenever we're looking at someone's ability to develop and grow a career or receive an education. So investigators have reported that for both men and women, having a larger body size when you control for other factors can be associated with lower starting salary offers made by a company. They've also found that for women specifically, that larger body size is associated with increased barriers to promotion over time and lower wage growth over time. So getting in the way of careers, not because the person themselves is any less capable, but because of perceptions by those around them and what they want the physique to be. Now, they've also looked at academic admissions and how that is impacting individuals. And scientists found that whenever you have academic admissions where a photo is available or an in-person interview was required, individuals with larger body size were actually less likely to be offered admission. And this was especially interesting whenever they would give actors scenarios in which they had the same resumes and were told to interview in a similar style, and the person with a smaller body size was more likely to receive the offer. So it can be quite stressful dealing with these factors on a day-to-day basis. However, whenever we look at those things that are most likely to hit home with someone over time, I think they're demonstrated most effectively by this particular study where 318 adults were interviewed about their experiences with weight bias and weight stigma. And the highest, most frequently related incidences of weight bias and negative comments that were also the most sustained over time came from the family. So from parents, siblings, and extended family members. So that far and away was where many of the people were receiving the most comments. However, a very close second to that, with both the frequency of negative weight bias as well as this sustained interaction with someone having negative weight bias, was with healthcare workers. And physicians were specifically mentioned just because they were asked about in this particular study, but with all healthcare workers. So if we think about what's occurring with weight bias in healthcare settings, whenever we're dealing with individuals, we can really look at what's happening at two different levels, the training stage and then the active practice stage. So one of the things that researchers tried to do is they looked at medical students who were the incoming cohort class of each year, so 2012 incoming cohort through 2017, and had them complete an implicit association test. So just a very quick image test where you see rapid-fire images, you respond with your quick preference, and it can reveal some biases sometimes that you may not have even been aware that you had yourself. I always say if you take this test and realize you have biases, it does not mean you should be ashamed, it means you should be proactive, because you have some awareness now in how you can approach your interactions. But if you look at this graph on the left, one of the things that they noticed was that consistently over cohort years, about 70% of students demonstrated a very strong preference for thinner body types whenever they would be presenting and working with patients. And only about 20% of students in any given year showed a more of a weight-neutral perspective. So then I asked those students, well, what do you think are some of the causes of someone having a larger body size, with this graph over on the right? And we can appreciate that people acknowledged, okay, genetics can play a role, poverty can play a role, social determinants of health, but then we still have to account for the fact that anywhere between 20 to 40% of participants said that they thought laziness was a major contributing factor to body size, which is an indicator of nothing, really. And I think that study is always an important one, because if you look at the cohort years for the medical student classes, those are currently our attendings, fellows, and residents, right, providing actual patient care. So when we move to the practicing physicians and healthcare workers now, some studies have also been done to look at, is there any existing bias or differences in how they're treating patients based on body size? And these other healthcare worker studies have mostly focused on registered dietitians and nurses, just to give you an idea of who those groups are. And overwhelmingly, long story short, the answer is yes. With physicians, dietitians, and nurses, you see sustained negative weight biases in which patients can be treated differently and have different healthcare options presented to them. So this group of scientists then decided that they should probably talk to the individuals themselves who are receiving care and see what their perspective was. And a few of the comments that were shared, for example, from this 63-year-old lady, one of the things she emphasized was that she felt that her doctor shrugged off a lot of her health concerns, but he told her at one point that he thought she just needed to learn to push herself away from the table, and that would solve a lot of her problems. It was later determined that this lady was perimenopausal and had a thyroid disorder, and her health significantly improved after those conditions were treated, but treatment was delayed. The second quote is actually from some qualitative work that we've done in our clinic setting when we look at relationships between HIV, nutritional status, and body image among our own patients. And the patient has commented that her doctor seemed almost upset that he had to talk about her blood pressure, possibly because he's an infectious disease physician having to take on more and more primary care responsibilities, but that he still seemed upset to her, and that he was telling her to lose 20 pounds and that this should be easy. But one thing she pointed out is he's the same size as me. So we look exactly the same, but I feel like he's telling me that something's wrong with me and something's not wrong with him. So we have to really think about what's going on whenever we're communicating with patients, even if we mean well, okay? Now, another thing that really sort of consistently came up was, okay, a lot of this is happening out in the general population. What is going on with weight bias in HIV care settings or in settings where research coordinators are dealing with study participants? And the first thing to note is that actually very little research is available on this. And the second thing I will note is that everything that I am going to talk to you about has focused on cis men and cis women. So that is clearly a very large gap in our understanding of how this can affect care. Now, one of the things we've seen is that in general, people with HIV who report being a larger body size do affirm that they've experienced more weight stigma whenever they're working with their care providers compared to someone with HIV of a smaller body size. Similarly to that, we've also seen that women with HIV report experiencing more weight bias than men with HIV from their care providers, okay? But one thing this doesn't really tell us is how does that compare to a population of a similar size that does not have HIV? And I mention that because technically, when it comes to research studies and clinical care, those of us working in the field of HIV should kind of be on top of this whole compassionate care thing, you know? We are working with patient populations who have experienced quite a bit of stigma in many areas. So that's something that should always be front of mind for us. So we had a group who did actually that exact thing. They took groups who were matched for their overall body size and then looked at whether they did or did not have HIV and what they reported as their stigma experience. Now, the first part of good news is that overall, yes, those with HIV did report less weight stigma. And this was the same whether you looked at age, race, or ethnicity. But when you looked at gender, the story was different. Men, who made up the majority of that group with HIV, did report experiencing less weight stigma from their healthcare providers. However, women with HIV reported more stigma from their healthcare providers. So we really, again, need to have front of mind, think about how we are actually presenting and interacting with these individuals whenever we're trying to provide care or complete research studies. And if we do switch from that compassionate care to somewhat more of an authoritarian approach, which can be the tendency when we're saying, I personally think this is a problem for you and I think you need to fix this, which happens a lot in these appointments, that can actually backfire. Okay? So when you have patients of similar body size and one person has been exposed to weight bias from their healthcare providers, it turns out in the long time that person actually has a longer time to medical diagnosis. They have delayed diagnoses for things that they should have received scans for, that they were told just go and lose weight. Surgeries have been delayed, sometimes past the point of when they would have been beneficial. Those individuals actually have an increased risk for continued weight gain compared to those who worked with a more compassionately trained provider. And they actually have had worse blood sugar control and increased cardiovascular disease risk compared to patients of a similar size who had a provider who had been trained in how to avoid weight bias. And it makes sense as well when you look at how the patient individually responds. There is more likelihood for depression, anxiety, increased binge eating episodes. But I think very importantly here is this whole idea of discounting feedback. So studies have shown that if you want to talk to someone about some of their chronic health conditions, their hypertension or their diabetes, and you go in and you open the discussion with how much weight they have gained or lost, and they're not in a headspace where they're prepared to hear that, they're more likely to discount the other healthcare advice that you provide them after that conversation. So it just delays improving their health outcomes long term, and they're more likely to avoid healthcare in general. And when we did these interviews with our own patients at our clinic, we found that we did have patients who sometimes had canceled or no-showed their clinic appointments because they just didn't feel like they could handle hearing the provider say, oh, well, I see you've gained weight. They're coming to us for their HIV care, for their antiretroviral therapy prescriptions. So we don't need to introduce additional bias there. So what can we do to try to minimize some of those negative interactions and provide this patient-centered care for patients of all sizes, and thinking today about when someone has a larger body size? Now, this is a reference, just really quickly, that I do recommend for you if you work with patients or if you work with research study participants or are a community advisor in this population. They give some really great information that you can use and take into your own practices. And to give you an idea of some of the things that we talk about in general, the first of those is to look beyond just body mass index or overall body size, right? So many people have heard of news media articles right now. It's the trend to say BMI is awful, BMI is useless, it does nothing right. It does exactly what it was designed to do. It tells us for large population groups whether they are getting larger or smaller over time. That is what it was designed to do. For an individual, the body size tells me nothing about how physically active they are, what they are eating, or what their own individual health risk is. I need to do due diligence and dig deeper. It's also important to screen for a history of addictive behaviors or disordered eating. If you are going to talk about whether someone's body size is getting bigger or smaller, or what you personally think it needs to do, you need to know if they have a history of bulimia, anorexia, or binge eating disorder. You could trigger a relapse if you're not approaching these topics in an appropriate manner. It might be that you don't need to approach it at all, if that is the case. As well, for some of our patients, they might have addictive behaviors. They might have struggled with substance abuse disorder, gambling addictions, a variety of conditions. And those individuals can oftentimes be at more risk to develop addictive behaviors towards exercise, or to become obsessed with trying to eat in a certain way to the point that their overall dietary pattern becomes very unhealthy for themselves. So you need to do a little bit of due diligence and make sure that you are not going to trigger any of these negative health conditions by having a conversation that the patient does not want or is not prepared for. And it's important to remember that the patient has the ultimate autonomy in the decision of whether or not to discuss any given health issue, right? So when we go into a visit, we have a very short amount of time, whether it's a research study visit, a clinical intervention, patient care. We have several things in mind that we want to say to the patient. They may or may not be ready to talk about those things in that day. So we may have to be patient and wait. They may never want to talk about them. And if that is the case, that's okay many times, because we can focus on a lot of health behaviors for the specific medical conditions that you're concerned about. So if someone is struggling with blood sugar control or high blood pressure levels, as a dietitian, I have a whole host of things that we can do. We have a lot of tricks that we can do to help bring those levels down, whether or not that patient's body weight itself is ever influenced. And that's something that to remember, is that body weight is one part of this equation, and its importance is going to vary from person to person, even here in this room. So we can do a lot of positive things for healthcare that don't involve body weight itself. And also considering the social determinants of health when you're giving advice to someone. So this woman who was told earlier that she just needed to learn to push herself away from the table, does she have a house with a table to push herself away from? Does she have enough financial resources to put food on that table? Or does she have a daily schedule that even allows her time to sit down at the table in the first place? We don't know if her provider knew any of those things. She didn't think they did. So you have to consider those. And the last thing that I want to leave you with as well is the situations in which a patient says, you know what, actually, I do want to address this. I am thinking that I might want to try to lose some weight. If they do, the first thing you really want to think about is being realistic about the impact of percent weight loss on health outcomes. So you heard earlier that they were looking at, in this one study, 5% weight gain because that's considered clinically meaningful, right? So that clinically meaningful versus statistical significance. If you lose 5% of your body weight and you are someone who is sensitive to those effects, that will do tremendous things for your metabolic health. And if you sustain that 5% loss, you will sustain those benefits. But guess what? You're still going to be overweight or obese by the health classifications. So helping someone be realistic and say, you're probably not going to be the same weight that you were when you were 16 years old. You don't want to be because you were still going through puberty at that point in time. You're probably, quite possibly, going to be in this size range forever, and there's absolutely nothing wrong with that. You can still meaningfully impact your health in many ways. It's also important to use all of the tools in the toolbox that you have. Ryan White Care is one of the few programs that does provide some funding for nutritional care. So being strategic in how we use those funds, referring to registered dietitians or board-certified specialists so that the patient is talking with someone who is actually trained in these areas and might be a little bit more sensitive to the care we hope these days. Also, not discounting the impact that some of your community health workers and trained age service organizations can provide. The support of someone else who's in a similar position in life and has also received some of this weight bias training can do tremendous things for someone. And providing that behavioral support, so we love to go in and tell someone, follow this diet, follow this exercise program, here's this handout. People can read. Whether it's our handout or the internet, quite often they are capable of reading these things. What people need support with a lot of times are the behavioral aspects of things, not to lose or gain weight, but just to follow through with being healthy in general. And I'm pretty sure every single one of us in this room could also use that behavioral support. And lastly, really thinking about medications that are available. So first of all, yes, looking at, does a medication switch need to be provided for medications that are already there, but also realizing we have a lot of newer medications that are available. That's an entirely separate talk. But being open to this if the patient is asked about it and does have access to them, and using them appropriately. And then the very last thing, which is I think probably the most important thing for all of this, is providing continued support during the weight maintenance period. And you notice I keep saying support, support, support over and over again, because size becomes irrelevant when someone has a good supportive healthcare system to help them live a healthier life in general, okay? You're gonna see good health outcomes when that happens. But one of the things we've realized is people love to say, diets don't work, this doesn't work, that exercise program does or does not work. Well, what we've done is looked at the people that we said, okay, who did this work for? And what we've realized over time is that the set of behaviors that are effective for helping someone to lose weight are very different from the set of behaviors that help someone maintain their current body weight after they've lost. And we love to have someone go through a weight loss program and then say congratulations and send them on their way. And they really need at least a good 12 to 18 months of continued support to shift over to the set of behaviors that are associated with weight maintenance, not just weight loss. It's kind of like if we prescribed someone art, got them down to an undetectable viral load, and then said, it was really nice knowing you, go out into the world and succeed, and we never followed up again. So sort of that similar thought process. So the thing to really remember at the end of this is that, again, each person is an individual. Whether or not someone's body size needs to change at the end of the day is going to be up to them, and we need to be really cognizant of approaching this in a very sensitive and appropriate way that doesn't turn them off, not just to their general health care, but to their HIV care even. So and I do want to thank this amazing team up here who's really helped educate me from the research and the clinical side, and our clinic team and patients who have been very willing to help us work through these issues and develop our own programs in clinic. Thank you.
Thank you so much, Dr. Willig. And to round out our presentations today, I'm pleased to introduce Dr. Julie Dumond, who is an associate professor in the Division of Pharmacotherapy and Experimental Therapeutics at the UNC School of Pharmacy in Chapel Hill. She has long experience in pharmacokinetic and pharmacodynamic research. She's going to share some of that with us today as she talks about sex differences in dolutegravir exposure and weight-related conditions.
All right, thank you, Jen, and thank you to the organizers for inviting me to talk about some of the work that I am doing within the cohort. You have 30% of the pharmacology working group within the MWCCS seated right up here. And I knew that Cecile was going to set the stage for me very well for this talk. So we are going to talk a bit about pharmacokinetics, and so I'm going to do a little bit of stage setting here at the beginning to talk about absorption, distribution, metabolism, excretion, which you may hear referred to as ADME. So these are kind of the physiologic factors that go into drug pharmacokinetics. And then my interest, the question is really in does sex, does age, do other patient-specific factors affect any of those ADME processes? And then the real question is, does that change patient outcomes, either in terms of toxicity or efficacy? And then I will talk about some of our PK approaches, research to try to answer some of these questions within the MaxWise cohort. I am not as creative as some of my colleagues, and so my studies do not have cool acronyms, but we have a prospective study, which is just simply DBT, PK, dolutegravir, bictegravir, tenofovir, PK, and then a backwards-looking one, which is retrospective analysis of metabolic outcomes in PK, or RAMO-PK. I'm going to try to avoid too much alphabet soup, but HIV drugs plus pharmacokinetics can result in a lot of that. So just a couple to point out to you: dolutegravir, DTG, PK, pharmacokinetics, and then two PK terms that will be important here are AUC for area under the concentration time curve, which is a marker of drug exposure, and then drug clearance, or CL, which is the removal of the drug from the body. All right, so just a quick overview of dolutegravir pharmacokinetics. So this is a concentration time curve here. This shaded in area is the area under the curve. For dolutegravir, that exposure is increased if the drug is taken with food. We can see that it reaches its highest peak concentrations, or Cmax, at about 2 to 3 hours, which is referred to as the Tmax. And we can see from this as well that it has a half-life of about 14 to 15 hours, so it's dosed once a day. And then in terms of its ADME properties, so about 70 to 80% of the drug is bioavailable, meaning that that percent of the dose It makes it to the systemic circulation. It's very highly protein bound, which is important because physiology can change the amounts of protein in the blood, and we consider only unbound drug to be pharmacologically active. In terms of metabolism, it is mostly glucuronidated by UGT1A1, which is good from a drug-drug interaction perspective because it has far fewer drug interactions than some of our older protease inhibitors and non-nuke drugs. Because of the metabolism, most of it ends up in the feces, but there is some of it that is renally eliminated into the urine as well. And we have some rough therapeutic targets for this drug as well. So PK people think about the world a little bit differently. And so we have this way of conceptualizing these curves into things like compartments, which are not physiologic things. They're just based on what we see in the curve and a way that we can think of to mathematically describe those curves. So dolutegravir PK is generally considered to have first order absorption, which is this Ka term here, and has first order elimination, so this clearance here. All first order means here is that those rates are dependent on the amount of drug that it's acting upon, and then a one compartment model, which again, we only see one curve when we look at the profile, and so that's how we term it. So again, the question is, well, we all know that everyone in this room is different. There's a lot of different physiologic variability between one person and another, and there are, definitely differences in physiology that could contribute in men and women that could contribute in differences. And again, I'll put the caveat here that this chart here specifically referring to cisgender, non-pregnant, premenopausal women. This is older research, and so this is where most of the data for this comes from. Right, and so if we think again to that ADME paradigm, there are lots of different ways that hormones and body size and things can affect these processes. And so we can see things like decreased oral absorption, tissue penetration, drug binding, and then changes in how the drug is removed from the system. And so the question here really then becomes, is any of this clinically significant, and can we detect it? Right? And so when we look at drug concentrations, you can kind of think of that as being like the outcome of all of these processes. We are not actually measuring the processes themselves. And so some of these things go up and some of them go down. And so things could be changing, but we don't see that in our actual measurements. Okay? Certainly it doesn't help as well that there's a bit of a demographic mismatch between our phase 3 clinical trials, which is where much of these PK data come from, and people that are living with HIV. So here on the left, this is a table that I'd kind of put together looking at approval studies for dolutegravir and TAF, tenofovir alafenamide. Overall there are about 16% women, not very racially diverse. And then there was another paper that kind of specifically looked at kind of the global population of people with HIV compared to these studies. This is not a very person-first way of presenting these data, but the kind of black circles here are Black or African American patients divided by sex. This is global, and then here for dolutegravir, you can see that that pie is much smaller, and so globally, white folks are overrepresented in our clinical trials. Now, to be fair to my colleagues in pharma, right, their goal for these studies is to get their drug approved. And they get their drug approved by showing that it works. And the easiest way to do that is by reducing the variability in the populations that you enroll into the study. They are definitely getting better. There has been a concerted effort to enroll more diverse participants into these studies. if only for the reason that we keep having drug toxicity that pops up unexpectedly when they're approved and let go into the world. Better to know that before rather than after. And so after dolutegravir was approved and we started seeing some of these side effects that hadn't necessarily been picked up in clinical trials, I started thinking about this and looking at the population pharmacokinetic data. So this is just an analysis technique that allows us to quantify and categorize the interpatient variability, right? And so, there's data that supports that sex affects the bioavailability, age affects the clearance, body weight itself affects clearance, and then there's also a pharmacogenomics component, really both for obesity and also for the metabolism of the drug. And many of these pharmacogenomic variabilities are tied to ancestry, so there may be differences by our sort of artificial constructs of race as well. And there are known PK/PD relationships between the concentrations and side effects. Most of this work has been done within the neuropsych literature, so things like sleep disturbances, some components of different scales that are used to measure these things, and headaches as well. And so Cecile did a great job of setting me up here, but the demographics of the weight gain that we're seeing with the integrase inhibitors kind of overlaps a bit with those groups that we would expect to have different pharmacokinetics. And so, that is sort of where I came in and said, well, is there a contribution here of the pharmacology? Of course, realizing that this is multifactorial. No one is expecting this to be the complete answer, but just to look at this and see if there is anything that we could do if there is a component of this to weight gain, and not just the weight gain, but also clinical outcomes. And so to do this, we really wanted to kind of over-represent these people that had not been well represented in the phase 3 trials, and the MaxWise cohorts and now the MWCCS is the perfect setting to do this in, because they're large cohorts, they have lots and lots of historical data on very well characterized patients. There are demographic differences between the cohorts, but one thing that they both are is old, so that is helpful in terms of looking at differences with aging, and then we can compare the men and the women to look at sex differences. So we did start this from data when the cohorts were separate, and now are continuing it into the merged cohort. So 2 ways to do this. The first is to try to add to our knowledge of those population PK studies by bolstering the number of women, the number of older people. I'm getting to be an old person, so forgive me for saying that. And Black or other races besides white. And so we have a prospective part, DBT PK. We have 4 sites, and we bring participants in and take serial blood samples from them over the course of a dosing interval. Our goal was to have 60 participants. We're looking not just at dolutegravir, but also bictegravir, and TAF comes along with that, because if they're on bictegravir, they're automatically on TAF, tenofovir alafenamide, and to really overrepresent women and older patients. We're about 85% enrolled, and we will be getting some data analysis of this in early 2024. I think we've probably got all the dolutegravir patients we're going to get, because we're seeing a lot more bictegravir use within our patients, but so these data will be coming to look at this. And then we have freezers upon freezers of stored biospecimens. And that is also paired with all this longitudinal data. And so we wanted to really take advantage of that and look at changes over time, look at pharmacology over time. And so this is where RAMO-PK comes in. And so we selected patients, and because we want to move past associations here with this really into more of a causal inference analysis. And so I was very disappointed when the epidemiologist told me that I could only pick people going backwards and not from the data that we already had, but from their point of switch. We tried to select folks who were suppressed, who had been coming to visits, who had been providing specimens, so that we could look at their drug clearance over time and look at that in terms of the outcomes. Body weight, HOMA-IR, which is a measure of insulin sensitivity. It has its own issues, but it is what was available to us in the cohort, as well as waist to hip ratio. We have done the selection for dolutegravir and TAF. Most of these patients, and we are looking at these in the separate cohorts, I should say. So most of these patients are people who were switched from the older tenofovir formulation to the newer tenofovir formulation, but we've got about 150 that switched to dolutegravir. The demographic differences here are really reflective of the demographic differences in the cohorts themselves. And then the bictegravir data will be coming. This ended in 2020, and so we didn't really have enough coverage in the cohort yet of that drug to select these folks. The important thing here, and I'm only going to show data on women, is because in the traditional MAX cohort, they recorded the time the samples were taken, but they didn't record when the patient reported their time of last dose. And elapsed time is our independent variable in the analyses that we do, but we're trying to work on some techniques to infer that. I'll talk about that a little bit at the end. This is unadjusted data in only the PK data set. Not every participant that we selected has samples available, so this is a little bit smaller than the numbers I just showed, but we are seeing some potential differences in the weight trajectory between non-white patients who are in the red and white patients who are in the blue. All right, and so modeling. So I will acknowledge that most of this work has been done by my amazing graduate student, Dr. Adrienne Coe. And in a perfect world, we would have already had the data from the prospective study to inform these sparse data from the visits. But thanks, COVID, we don't have that. And so we looked into the literature to find the best available study that we could. And this was just our sanity check. So the black dots are our actual data, and then the blue shaded area is kind of some simulations from that published model to at least see that we had like a reasonable match between where we were starting and what had been published. So we looked at a lot of different potential influences or covariates on the clearance of dolutegravir in volume that we all had available in the cohort. And then we are also doing pharmacogenomics that is in process with Dr. Bonnie Tamraz here at UCSF. But we got the model that we expected based on the literature. And then we are able to look at the interindividual variability for clearance and volume, and at least for clearance we saw significant influence of the amount of time that they have been on dolutegravir. This is, I'm not by any means saying that like a 3% change is clinically significant at all, but this is what came out of the analysis. Current smoking increases clearance by about 26%. A higher bilirubin is associated with lower dolutegravir clearance, which is consistent with lower activity of that UGT1A1 enzyme. And then, as has also been seen in the literature, dolutegravir has increased clearance with body weight. And this is just body weight at the time the sample was taken, not looking at any changes. And so now the next step is to use these PK measures to move into the causal inference part, which, we're never going to go back and do any kind of randomized study, but we have a lot of non-randomized comparisons that we can make. And so we've spent a lot of time constructing these causal inference models. These are they call them the DAGs, that kind of try to map out how all of these potential factors are interrelated to each other. And this has really been done by Yen Chang, who's a biostatistics student at UNC who's been working on this. And so we have these for weight. Our drug clearance is our exposure. Also for HOMA-IR, there's some subtle differences between these. And then as well for the waist to hip ratio. It has taken a very long time to get these data sets together and cleaned up, but I'm really looking forward to beginning this analysis. And then back to the whole, we don't have our X variable issue in the max. Again, Adrienne, my amazing graduate student, is evolving a way to look at this and estimate it, based on, we know something about the distribution of the concentrations over time, and then assuming that the Ys and the max, because they were doing similar protocols, have kind of a similar distribution of sampling times, we can kind of use these joint probabilities together to kind of pick out some times from the buckets, if you will, reanalyze the data, and then be able to come up with reasonable estimates. This is working pretty well on the Ys data so far. We're about ready to move into the max. There are some changes that we're going to make because all these patients are on multiple drugs. We can also look at some other drugs that are there, specifically lamivudine and emtricitabine, which have a wider range of concentrations and are less variable overall, so help to decrease some of that overlap between the concentration buckets. And then also, again, this is being based on the women's PK. So once we have the prospective PK, we can go back and better inform that based on the data from the men. All right, so thank you to everyone that has helped with this, our funders, NIAID, NHLBI, our CFAR, and then thanks especially to Adrienne and Yen, my graduate students that have been really put in some labor on this, as well as Catalina Ramirez, who's back there someplace, who's amazing, and Andrew Edmonds, who is our data manager at UNC. That's it.
Thank you, Dr. Dumond, and thank you to all of our amazing presenters for a fantastic session. We do have some time for question and answer, and our panel is eagerly awaiting your questions. So if you do have a question, if you could please remember to move to the mic so that your question is captured by everybody.
Hi, thank you for the amazing presentations. I'm Lisa Bavel from Mass General Hospital. I really had a question for Julie about your presentation. I was interested in the decline of drug levels over time. You said 3% over 6 months probably isn't significant, but I'm just curious, does that add up over time? And do you see this other drugs? Is there anything meaningful about that, or too early to tell?
Do I have to turn this on? It's on, okay. That's a good question. We haven't fully explored that yet. And again, we've only gone out, I think most of our patients, we've got about 2.5 years of data. So, it could change in time. And again, it also depends on where you started in terms of your drug clearance. So I think we'll be better able to capture that a little bit once we get into the more kind of involved causal inference analyses. It doesn't seem to, so far, track with age, but again, we're only looking over, a couple of years, and so absent any kind of clinical event, right, like your clearance function may not change that much from like 50 to 52. So I think that's something that we'll continue to look at.
Thank you, Dr. Lahiri, for your presentation. I was curious as to why you chose a BMI of less than 30, and if you could have used to be, 24.5. And also, were the results I wanted to know if you looked at differences based on age, stratified by, those older and younger age group. When we talk about drug clearance and things like that, if older people, clearance rate is different. So, and I guess also I wanted you to talk more about pyridoxine and the folate. So I saw there were differences from the results. I don't know if I made a mistake, but I really enjoyed the results on your so I would like more I guess explanation as to the thyroxine, and then the thyroxine that was higher among those with HIV, right? I don't know if I'm asking so many questions, but it was interesting. I'm curious. Thank you.
Okay, yeah. I think that's 3 different questions. Hold on, I might forget, but thank you so much for those questions. So the reason why we chose a cutoff BMI of 30 is actually, that's a very easy answer. So in our WISE cohort, the average BMI for our women in the cohort is close to 30. So when we did try to look at cutoffs of BMI less than 25 or anything that would be considered overweight or obese, we don't have the sample size for that because it's just very skewed. So that's why we chose that BMI cutoff. That's a population of women. And then we did look at weight gain stratified by baseline characteristics, and we did look at an age cutoff of 50 was our age cutoff, and we found that women who were over the age of 50 did have greater magnitude in weight gain. And then your third question, I think, was the metabolomics. So those were, I was showing all the bar graphs were metabolites that were significantly different between the women who later gained weight versus those who maintained their weight. And so I just selected 2 examples. We looked at every single, it's a very tedious process, so we looked at every single metabolite, and I could have shown you those graphs for 15 metabolites, but I kind of picked 2 that were kind of in examples of how we constructed the pathway that I showed on the next slide. But I have every single one of those graphs. But it was just kind of a way, how were we using metabolomics to differentiate between women who actually it's predictive of future weight gain, because all of those samples were taken before they had any exposure to those drugs. I hope that answers your questions.
My question's for Cecile. You called it the age of INSTIs, but it's also the age of GLP-1 receptor agonists.
Yeah.
And I was wondering if you could, if what's known about using GLP-1 receptor agonists in the population of women with HIV and ART, its efficacy and even its safety.
Yeah. Yes, all the data I showed you was pre-GLP-1 agonist, but there was actually interesting data presented on that at ID Week, not exclusively in women, but in persons with HIV, showing the impact of these GLP-1 agents on weight loss, and of course limited by short-term follow-up that we have, and they are effective. I think what's unknown is the longevity of that weight loss once the medications are stopped. They seemed, the data that was presented, and it was presented by Grace McComsey, So that's really, good. I don't think it's been published yet, but that was presented at ID Week a couple months ago. And I think it was well tolerated. The most frequent side effects, and I don't think it necessarily differs between persons living with or not having HIV, is nausea and stomach upset, maybe some injection site reactions, but it was well tolerated. I think one of the interesting things that she did show is that there was some, they had done, I think, whole body DEXA scans, or perhaps it was CTs, but did show some signal of some lean body mass loss, which, that not ideal, but we don't know what those kind of long-term consequences are. So that's what we know so far. I think there's going to be much more data forthcoming, but they seem to be at least effective while people are on the drug, and well tolerated. And I think it remains to be seen if people can maintain that weight loss after they stop the medication.
Thank you.
And I will piggyback on this quickly to say that it's important to recognize that those medications are meant to be used long-term. So they're not meant to be used for 6 months or 1 year. They're meant to be used for years in the same manner that you would use a statin or an antihypertensive. So we know that after 2 years, if someone stops a GLP-1 or a GLP-1 GIP agonist, they will regain a portion of that weight. So just consider when you put your patients on these, you should be supporting them to be on these medications for the long term.
I'll also say too that as far as I'm aware, they did not stratify the patients in those studies by their drug regimen. And so hopefully that will also be included in the published results. And there is some interest in looking at this within the MaxWise cohort, at least from our, we're still kind of waiting for the data from our most recent visit. There was not really a ton of usage in the cohort from what we have, but we're expecting to see that increase over time, and are planning to follow that in the patients in the cohort who are on it, not just from a weight loss standpoint, but I think there will also be a lot of patient access issues that come along with that, since those drugs are not cheap.
Thank you.
Yeah, I just wanted to add what you were saying. Practicing in Philadelphia, we are struggling to get access to it. I mean, it's really, really hard. We have so many people we wind up sending towards the bariatric surgery, but we know that if we could get the approval, so we're waiting, and hopefully we can get access to that, but it is very difficult and takes very long periods of time to get approval.
And I think, as she mentioned, we're seeing in populations with and without HIV, because this is rapid weight loss, you will see things happening at a faster level. So you need to also be providing appropriate counseling and care for physical activity and for certain dietary practices that are associated with reduced nausea and gastrointestinal side effects. Physical activity to reduce the incidence of loss of lean mass for these patients, to set them up for better long-term outcomes. So if you have a provider prescribing the medications who's not trained appropriately or who's not seeking out the training, they could do harm when these medications actually have the potential to provide many benefits.
Hi, Lauren Collins from Emory. This has been a fantastic session, so thank you guys. And obviously, weight in women is a very complex issue, and so I guess sort of turning the tables a little bit, I'm curious for the panel, and especially Amanda's guidance on, approaching a patient encounter as a clinician and balancing sort of the negative consequences of excessive weight in terms of all the cardiometabolic outcomes we're talking about, with a desire to maintain a heavier weight because, especially practicing in the South, healthier weight, and having curves, especially in communities of color, is very attractive. And sometimes women are not at all interested in losing weight. And so I guess any sort of guidance around that dialogue would be really helpful.
So I know whenever I work with patients, one of the things that we say is, what do you feel ready to do at this time? And as I already said, we can improve many of your metabolic health situations with just generally trying to be physically active, trying to eat well. What we find that people struggle the most with is reactions from their other family members, especially in the South. So if a physician is blanket across the board saying you need to lose weight, and this person is scared that they'll lose weight, and then people will think that that means they have HIV. So they'll feel they'll be outing themselves if they lose weight. We look at that in Alabama. So we say, okay, we have ways to do this without looking at weight as the focus. And I think that's the main thing to approach. We also have individuals who've had family members who will say, I don't want you to lose weight. They'll try to start providing extra food and treats if the person does start to engage in a health behavior program to try to prevent them from losing weight. So we've seen a lot of those complicated things. So we try to pair our nutrition counseling and our physical activity counseling with general counseling from our counselors and from our psychologists, because losing weight at any point in time is actually associated with increased risk of depression and anxiety and potentially suicide risk. When someone sometimes sees how they're treated in a smaller body versus how they were treated in a larger body, that can be emotionally shocking. And some of the hormonal shifts that happen with weight loss, regardless of the speed, can increase risk for depression and anxiety, at least temporarily. So for us, that's the big thing, is providing that counseling. And again, acknowledging that someone at a larger size, even if gaining that weight was associated with some metabolic disturbances, we can correct most of that without you actually having to lose weight.
I think that actually concludes our panel discussion. So I want to thank you for your engagement and thank our speakers again for some fantastic presentations.